Hello, everyone. Welcome to PodBites, where we break down complex medical topics into bite sized pieces, perfect for your commute, coffee break, or whenever curiosity calls. I'm Hala, your host for today's episode, and I'm joined by Ghena to discuss a foundational topic in orthopedics and pathology bone diseases. We'll be covering metabolic bone diseases, congenital bone diseases, and bone infections.
Hey Hala, great to be here. Bones might seem static, but they're incredibly dynamic organs. When their metabolism, development, or integrity is disrupted, it can lead to a wide range of significant health issues.
So, before we dive into the specifics, Ghena, can you give us a quick primer on what these categories are all about?
Absolutely. Let's think of it in three parts. Firstly, we have metabolic bone diseases, which are all about imbalance. It's when the constant lifelong process of bone remodeling, where osteoblasts build bone and osteoclasts resorb it, gets imbalanced, leading to bones that are either too dense or, more commonly, not dense enough, making them fragile. Secondly, we have congenital bone diseases, which are genetic. They're caused by mutations that affect bone development from the get go, leading to structural problems like dwarfism or bones that are brittle from birth. Lastly, osteomyelitis is an infection. It's an inflammation of the bone and bone marrow, usually caused by bacteria that travel through the bloodstream or from a nearby infection, leading to pus formation, necrosis, and a real battle within the bone itself.
That's a perfect setup. Let's start by exploring the world of metabolic bone diseases. Okay, Rena, let's start with a classic case. Imagine a 68-year-old woman comes to the clinic. She's thin, Caucasian, and she slightly tripped on a rug at home. She didn't fall hard, but now she's got this terrible, sudden back pain. An x ray shows a compression fracture in her spine. What's the first thing that comes to your mind?
Immediately, Hala, I'm thinking of osteoporosis. That story, a minor stress causing a major fracture in a postmenopausal woman, is practically textbook.
Osteoporosis? The brittle bone disease? Can you break it down for us? What is actually happening inside the bone?
Okay, so think of a bone as a living structure that's constantly being remodeled. Teams of construction workers or osteoblasts building new bone, and demolition crews or osteoclasts breaking down old bone. In osteoporosis, the demolition crews, osteoclasts, become far more active than the builders, the osteoblasts. Over years, this tiny daily imbalance adds up. The bone loses mass, the cortex gets thin, and the internal tuberculae become fewer and less complex. The entire structure becomes porous and fragile.
So it's a slow, silent weakening? Does this always happen all over the body or can it be localized?
Great question. It actually can be both. Localized osteoporosis happens when a limb is out of action, like in a cast. The disuse eliminates the weight bearing stress that normally tells the bone to stay strong. Without that signal, bone resorption runs rampant in that specific area. Meanwhile, generalized osteoporosis affects the whole skeleton, and this is where we see two main types.
Okay, Rena, can we talk about those types then?
Of course. So, type 1 or primary osteoporosis is the one we most associate with postmenopausal women and the elderly. In women, the key trigger is the drop in estrogen after menopause. Estrogen is a natural brake on osteoclasts. When it's gone, cytokines like interleukin 1, interleukin 6, and TNF surge. These are like a megaphone screaming, activate, activate, to the osteoclast, massively speeding up bone loss. The SENA form is just the effect of aging on all our cells, including our bone building osteoblasts slowing down. Type 2, or secondary osteoporosis, happens because of an underlying issue. A very common cause is drugs, especially long term corticosteroid use, which directly wreak havoc on bone metabolism.
Given how silent this is, when should we actually start looking for it? Is it just when someone breaks a bone?
No, we absolutely should not wait for a fracture. Screening is vital. The standard is to screen all women aged 65 and older with a bone density test.
What about a 55-year-old woman? Does she just wait another decade?
Not necessarily. We definitely screen women under 65 if they have significant risk factors. For example, if she's postmenopausal and also a smoker, has a family history, or is on long term steroids, we wouldn't wait.
And the test we use for the screening and diagnosis is the DEXA scan, right?
Exactly. A regular x ray is like looking through a foggy window. You will only see the problem when it's really advanced, after 30 to 40% of bone is already gone. The DEXA scan is the gold standard. It gives us a clear, precise measurement of bone density to catch the disease early.
Okay, Rina. So once we've diagnosed it, what's the game plan for treatment?
So it's going to be a multidimensional approach. Prevention with weight bearing exercise and calcium and vitamin D is foundational. For medications, the first line is bisphosphonates, which specifically target and slow down those overactive osteoclasts. helping to tilt the balance back in favor of bone building.
Amazing breakdown. Let's test our listeners. What is the core cellular imbalance that defines the pathogenesis of osteoporosis?
It all comes back to osteoclastic bone resorption, chronically outpacing osteoblastic bone formation.
All right, let's move to our next case. We have a patient with a long history of renal failure who comes in complaining of significant bone pain and some noticeable deformities. We get an x-ray of their hands, and it shows these peculiar bulbous swellings at the fingertips and what look like multiple cystic cavities within the bones themselves. What disease is painting this picture?
That constellation of findings, renal failure, bone pain, and those specific X-ray changes is a classic presentation for osteitis fibrosa cystica, which you might also hear called von Recklinghausen's disease of the bone.
Osteitis fibrosa cystica? Break down that name for us. What's happening at its core?
It's a bone disease driven by hyperparathyroidism. The key player is an excess of parathyroid hormone. Here's the chain reaction. The high PTH levels first activate osteoblasts. But that activation isn't for building. It's a signal that then stimulates osteoclasts to go into overdrive, aggressively resorbing bone. This creates widespread osteolytic lesions, and the body tries to patch up the holes with fibrous tissue, which leads to the formation of those cysts and tumor-like masses.
So the root of the problem is always this high PTH. Where is it coming from?
Exactly. We look at the source. In primary hyperparathyroidism, the problem is within the parathyroid gland themselves, like an adenoma or hyperplasia, which causes them to oversecrete PTH independently. While in secondary hyperparathyroidism, this is a compensatory response. The most common scenario is prolonged hypocalcemia, often from renal failure. The kidneys aren't working properly, which messes up calcium and phosphate balance, leading to low calcium. The body's response is to pump out more PTH to try and pull calcium from the bones and raise its levels in the blood.
And on the x-ray, you mentioned those bulbous swellings, the brown tumors. What exactly are we looking at here?
The brown tumor is the hallmark diagnostic clue. It's important to note these aren't true cancers. They are reactive masses filled with a few key ingredients. A huge number of osteoclasts, the fibrous tissue that's replaced the bone, and old blood that breaks down into hemosiderin, which gives them their characteristic brown color. Seeing these on an x-ray, especially in the hands, is a massive red flag.
So, to put you on the spot, if you're looking at a hand x-ray and you see these brown tumors, what's the very first diagnosis that should pop into your head?
A hyperparathyroidism, every single time. That's the underlying engine for this entire process.
And treating it means going after that engine, right?
Precisely. You treat the root cause. For a primary adenoma, the solution is often surgical removal. For secondary hyperparathyroidism from renal failure, the focus is on managing the kidney disease and meticulously balancing calcium and phosphate levels.
All right. Now let's tackle our final metabolic case. We have a 45-year-old woman with a known history of systemic lupus erythematosus, or SLE. She's been on long-term, high-dose corticosteroids to manage her condition. She now comes to us complaining of a persistent, deep pain in her hip. We get an MRI, and it shows a very distinct, wedge-shaped area of dead bone in the femoral head. What are we looking at here, Ghena?
This is a textbook case of avascular necrosis, which we also call osteonecrosis. That wedge-shaped finding on the MRI is the classic giveaway.
Avascular necrosis? The name says it all. Break it down for us.
Essentially, it's an ischemic infarction of the bone and bone marrow. Just like a heart attack is due to a blocked blood vessel in the heart, this is a bone attack where the blood supply to a section of bone gets cut off, and that tissue dies.
And in this case, the culprit seems to be the corticosteroid treatment for her lupus. How does that happen?
That's the most common cause. Long-term, high-dose corticosteroid use causes fat cell hyperplasia inside the bone marrow. The marrow is a confined space, so all that extra fat increases the pressure inside the bone, which literally squishes and compromises the small blood vessels, cutting off the flow.
So it's a pressure problem from the inside. Are there other ways this can happen?
Absolutely. Trauma is a big one. A femoral neck fracture can directly sever the blood vessels. In sickle cell disease, the misshapen red blood cells can clog up the tiny vessels, creating microthrombi. The most common sites for this to occur are areas with a vulnerable blood supply, like the femoral head in the hip and the scaphoid bone in the wrist.
Can you explain the different ways it presents?
Certainly, where the necrosis occurs changes the clinical picture dramatically. We have medullary infarction. This happens in the inner cavity of the bone. It involves the marrow and cancellous bone, but it's often clinically silent and stable because it doesn't affect the structural integrity of the joint. On the other hand, there is subchondral infarction, which is a critical one. It occurs in the bone just under the articular cartilage. You see that characteristic wedge-shaped area of necrosis, and while the overlying cartilage might be viable at first, the dead bone underneath can't support it. This often leads to collapse and is a major precursor to secondary osteoarthritis.
And this isn't just an adult disease, is it? I've heard of specific conditions in children.
Correct. There are specific pediatric forms, like Calpurni's disease, is avascular necrosis of the ossification center in the femoral head. It typically affects children between 3 to 10 years old, more often boys, and they can present with a limp or even complain of knee pain, which can be a misleading clue. There's also collar disease, which is technically the same process, but it affects a navicular bone in the foot.
I see. So back to our patient with the painful hip. The MRI confirms subchondral avascular necrosis. What can we do for her?
The goal is to always preserve the native joint for as long as possible. In early stages, we might do a core decompression, which is like drilling a hole into the area to relieve the internal pressure and hopefully stimulate new blood vessel growth. For larger areas, a bone graft might be needed to provide structural support. Unfortunately, if the bone has already collapsed, the only option to relieve pain and restore function is often a joint replacement.
It's tough to think that a treatment meant to help can lead to something so serious. Thank you for explaining that so well, Ghena. We've covered a lot of ground with these metabolic bone diseases now. Before we move on, let's do a quick recap for our listeners. Can you highlight the absolute high yield points for osteoporosis, osteitis fibrosa cystica, and avascular necrosis?
Absolutely, Hala. Let's break them down together.
Great. Starting with osteoporosis, what's the one sentence takeaway?
For osteoporosis, remember, resorption over formation. It's a systemic imbalance where osteoclast activity chronically outpaces osteoblast activity, leading to porous, fragile bones. The classic patient is always going to be a postmenopausal woman who presents with a fragility fracture like a vertebral compression fracture from a minor trip. Diagnosis is always going to be with a DEXA scan, and first-line treatment is bisphosphonates.
Perfect. Now, osteitis fibrosa cystica. This one has a very specific trigger.
Exactly. The high yield point is the direct link to hyperparathyroidism. If you see a brown tumor on an X-ray, your mind must immediately go to high PTH levels. It's a disease of excessive bone resorption driven by overactive osteoclasts, and the treatment is all about addressing the underlying parathyroid issue, whether it's a primary adenoma or secondary to renal failure.
And finally, avascular necrosis. What's the core concept and the big association?
Avascular necrosis is a bone attack due to interrupted blood supply. The most important testable association is with long-term high-dose corticosteroid use. The mechanism is fat hyperplasia in the marrow, increasing intraosseous pressure. The MRI showing a wedge-shaped subchondral infarct is diagnostic. Remember, the subchondral type is the one that leads to joint collapse and secondary osteoarthritis.
So, to summarize this cluster, osteoporosis, think systemic, slow, silent bone loss. Think more resorption and less formation of bone in postmenopausal women. Osteitis fibrosa cystica, think focal, aggressive bone resorption. Think brown tumor is equal to hyperparathyroidism. And finally, avascular necrosis, localized bone death. Think steroids leading to hip pain, leading to a wedge-shaped infarct on MRI.
You've got it, Hala. Those are the crucial high-yield distinctions that will help keep them straight.
Let's move to the next section with our first congenital case. A newborn is evaluated, and the pediatrician notes something distinctive. The baby has a normal-sized head and trunk, but significantly shortened arms and legs. Both parents are of average height, and there is no known family history of this condition. The doctor also makes a point to say the child's intelligence is expected to be completely normal. What condition does this classic presentation point to?
That's a perfect description of achondroplasia, which is the most common cause of disproportionate dwarfism.
Achondroplasia. So this is a problem with how the bone forms from the start. What's the fundamental defect?
It's an autosomal dominant condition where there's impaired proliferation of cartilage at the growth plate. This process, called endochondral bone formation, is how our long bones grow in length. In achondroplasia, this process is defective, so the long bones, the arms and legs, just don't form to their proper length.
And this is caused by a specific genetic mutation?
Yes, it's very specific. It's caused by a point mutation in the FGFR3 gene, that's the fibroblast growth factor receptor 3. Normally, this receptor helps regulate bone growth, but this specific mutation makes it overactive, which essentially puts the brakes on cartilage cell division at the growth plate.
So the molecular pathogenesis is that this mutated FGFR3 receptor leads to a decreased endochondral bone formation and premature ossification of the growth plate, stunting long bone growth.
Precisely, you've got it.
Now, back to the clinical picture. The normal intelligence and normal size head are key differentiators, aren't they?
Absolutely, those are crucial diagnostic clues. Patients have disproportionate short stature, short limbs with a normal size head and trunk. They have normal intelligence, a normal lifespan, and normal reproductive ability. And here's a critical lab point: their growth hormone and IGF-1 levels are normal as well. This is what definitively distinguishes it from pituitary dwarfism, where those hormone levels would be low.
And for treatment. Since it's genetic, there's no cure, so management is about managing complications.
Correct. There's no cure for the underlying condition. Treatment is supportive and focuses on monitoring for and addressing complications that can arise, such as spinal stenosis or recurrent ear infections, to ensure the best possible quality of life.
Okay, Ghena, let's look at another concerning case. A baby is brought to the emergency room with multiple fractures after what seems like a very minor handling, nothing that would normally cause a break. The examining doctor also notes something unusual. The whites of the baby's eyes have a distinct blue tint. What brittle bone disease does this scenario point to?
That presentation is a perfect textbook description of osteogenesis imperfecta, or OI, which is commonly known as brittle bone disease.
Osteogenesis imperfecta. So, the problem is with the very fabric of the bone itself?
Exactly. At its core, it's a group of genetic disorders characterized by defective synthesis of type 1 collagen. Think of collagen as the steel rebar that gives the bone its tensile strength. If that rebar is faulty, the entire structure is weak. And because type 1 collagen is also a key component of the sclera, teeth, and skin, all those tissues will also be affected.
So, it's a systemic condition. What causes this collagen defect?
Now, most types are autosomal dominant, caused by mutations in the genes that code for the alpha 1 and alpha 2 chains of type 1 collagen. It's a fundamental error in the body's blueprint for making this crucial protein.
And that single error explains all the diverse symptoms. Walk me through the diagnostic clues.
Certainly. So, the most obvious sign is pathological fractures from minimal trauma, which can even occur at birth. The blue sclera is a classic clue. It happens because the defective collagen makes the sclera so thin that you can see the underlying choroidal veins. Patients can also develop hearing loss later in life due to fractures in the tiny bones of the middle ear. Dental imperfections, a condition called dentinogenesis imperfecta, and thin skin that bruises easily. It's important to know that type 2 osteogenesis imperfecta is the most severe form and is often lethal in utero or shortly after birth.
With such a fundamental genetic cause, what's the approach to treatment?
Now, there's really no cure, so treatment is entirely supportive and focuses on managing the symptoms. This involves careful fracture care, physical therapy to maximize mobility and strength, and sometimes medications like bisphosphonates are used to help increase bone density and reduce fracture risk, though they don't fix the underlying collagen problem.
So it's really about comprehensive care and improving quality of life.
Sadly, yes, it's a condition that truly demonstrates how a single protein defect can have such widespread consequences.
Okay, Rina, here's a puzzling case. Let's see if you can guess this one. A child is brought in for frequent, seemingly easy fractures. It's confusing because when we get x-rays, the bones don't look weak. They look abnormally dense and opaque, almost like marble. To add to the mystery, a blood test comes back showing pancytopenia, low counts of all blood cells. How can bones that look so dense on a scan be so fragile? And why would that cause a blood problem?
Now, that apparent paradox is the absolute hallmark of osteopetrosis, often called marble bone disease. It's a fascinating condition where the bone's appearance is completely deceptive.
So, if the bones are dense but weak, the problem must be with the quality, not just the quantity of the bone.
Exactly. The core problem is a defect in osteoclast function. Osteoclasts are the cells responsible for breaking down and resorbing old bone, so it can be remodeled. In osteopetrosis, they can't do their job. The most common pathogenesis is a mutation in the gene for the carbonic anhydrase 2 enzyme. This enzyme is crucial for creating the acidic environment osteoclasts need to dissolve bone mineral. Without it, osteoclast function is crippled.
So the construction crews, the osteoblasts, keep laying down new bone, but the demolition crews are on strike. The bone isn't being remodeled properly.
That's a great way to put it. You get uncontrolled bone formation without the necessary resorption, leading to osteosclerosis. Those super dense bones on the X-ray. But this bone is structurally disorganized and brittle, which is why pathological fractures are so common.
And the pancytopenia, how is that connected?
Now that's the other critical piece. As this primitive, dense bone accumulates, it literally obliterates the bone marrow cavity. There's no space left for the marrow to make blood cells, leading to the pancytopenia we see. In fact, if you look at a blood smear, you might see a leukoerythroblastic picture, immature red and white blood cells that have been pushed out into the bloodstream early because the bone marrow is so crowded. It's a benign, reactive process, not leukemia.
So the body has to find another place to make blood cells.
Yes, it tries to compensate through extramedullary hematopoiesis, primarily in the liver and spleen. This causes them to enlarge, which we see as hepatosplenomegaly.
And I imagine all that excess bone growth can cause other problems by pressing on things.
Definitely, the overgrowth of bone narrows the passage in the skull. This can even lead to cranial nerve impingement, most commonly affecting nerve 7, the facial nerve, and 8, auditory nerve, causing facial palsy and deafness. It can even narrow the foramen magnum, potentially causing hydrocephalus.
Let's talk about radiology again. You mentioned the dense bones, but is there a specific shape we look for?
Yes, there's a key radiographic finding known as the Erlenmeyer flask deformity. The ends of the long bones, the metaphysis, become broadened and flared, resembling the shape of that classic laboratory flask.
And if we were to look at a piece of this bone under a microscope, what would we see?
Histology would show the root of the problem, disorganized primitive bone trabeculae and a complete absence of the normal bone marrow space. It's just bone packed in with no room for anything else.
Finally, what about inheritance and treatment?
Now, it can be inherited in different forms. The autosomal recessive type is severe and presents in childhood, like our case here. The autosomal dominant type is typically much milder and might be discovered incidentally in adulthood. Because osteoclasts originate from bone marrow stem cells, the only definitive treatment is a bone marrow transplant, which can provide a new population of healthy, functioning osteoclasts.
A truly complex condition where the treatment is as targeted as the cause. Thank you for unraveling that paradox, Ghena. We've just covered 3 major congenital bone diseases, Ghena. Let's do a quick recap to highlight the absolute high-yield points again. How can we best distinguish between achondroplasia, osteogenesis imperfecta, and osteopetrosis?
Absolutely, Hala. The key is to focus on the core problem and the classical clinical image for each one.
Let's start with achondroplasia. What's the one-liner?
So, for achondroplasia, think the short-limbed dwarf with a normal head and normal intelligence. The fundamental defect here is a mutation in FGFR3, causing defective endochondral ossification at the growth plate. Crucially, remember that growth hormone levels are normal, which distinguishes it from pituitary dwarfism.
Got it. Now, osteogenesis imperfecta, the brittle bone disease.
For osteogenesis imperfecta, think fragile bones and blue sclera from bad collagen. The high-yield takeaway is the defective type 1 collagen synthesis. This explains the pathological fractures, blue sclera from thin collagen showing underlying veins, hearing loss, and dental problems. Remember, type 2 is often lethal in utero.
Now, osteopetrosis is the real paradox. How do we summarize that?
Osteopetrosis is the dense, brittle bones with no marrow space. The high-yield takeaway is the pathogenesis, a defect in osteoclast resorption, often due to a carbonic anhydrase 2 mutation. This leads to the classic triad: 1. Fractures in dense bones, 2. Pancytopenia from marrow obliteration, and 3. Cranial nerve palsies from foraminal narrowing. The treatment is as targeted as it gets: a bone marrow transplant.
So, to summarize this cluster for our listeners, achondroplasia is a problem of forming long bones. Think short limbs, normal intelligence, FGFR3. Osteogenesis imperfecta is a problem of bone quality. Think fragile bones, blue sclera, and defective type 1 collagen formation. And finally, osteopetrosis is a problem of breaking down bone. Think dense bones, pancytopenia, and defective osteoclasts.
You've nailed it! Keeping those core concepts separate is the key to mastering these bone diseases. Remember the keywords: FGFR3, type 1 collagen, osteoclast defect, and disordered remodeling.
All right, listeners. I hope you're not tired yet. We have 2 more patients to diagnose. Let's take a look at this case. We have a teenage boy with a known history of sickle cell disease. He presents with a fever and a dull, constant pain in his thigh that isn't related to movement. The area is warm and swollen to the touch, and he hasn't had any recent trauma. Given his underlying condition, what's the top concern here?
Now, in a patient with sickle cell, this constellation of symptoms should immediately raise a very high suspicion for osteomyelitis. This is an inflammation of the bone and bone marrow caused by an infecting organism.
So, this is a bone infection. How does it actually take hold and cause damage?
The pathophysiology is like a pressure cooker inside the bone. It starts with an inflammatory exudate forming in the marrow. This leads to a dangerous increase in intramedullary pressure. That pressure forces the exudate out through the bone cortex, which in turn interrupts the blood supply. Without blood flow, a segment of bone dies. This dead, separated bone fragment is called a sequestrum. The most common site for this entire process is the metaphysis of long bones, as it has a relatively vulnerable blood supply.
And the culprit organism? I've heard there's a specific link with sickle cell patients.
You're absolutely right. While the most common organism overall is Staphylococcus aureus, patients with sickle cell anemia have a unique predisposition to osteomyelitis caused by Salmonella. It's a classic association. There are other specific pairings too. For instance, osteomyelitis following a puncture wound through a sneaker is often caused by Pseudomonas aeruginosa, and osteomyelitis from a cat bite is likely due to Pasteurella multocida.
So, back to our patient. We're clinically suspicious. How do we confirm the diagnosis?
The diagnostic clues in our case include constant pain, fever, and local signs of inflammation. Labs will often show elevated white blood cells, ESR, and CRP. For imaging, an MRI is the most specific test, beautifully showing bone marrow edema and early destruction. However, the gold standard is the most accurate diagnostic test is a bone biopsy with culture. This is the only way to definitively identify the causative organism.
And once we have the diagnosis, what's the comprehensive treatment plan?
Treatment is a rigorous two-pronged attack that you cannot skip on. Now, the first treatment attack is the most accurate treatment, starting with surgical debridement. You must physically remove all the necrotic infected bone, the sequestrum, and any infected soft tissue to get rid of the source. Now, the second treatment attack is followed by long-term IV antibiotics for 4 to 6 weeks. Empiric antibiotic selection is based on the suspected organism. For a sickle cell patient, you'd cover for Salmonella and Staph. Common regimens include something like a ceftriaxone or ciprofloxacin, 4 gram negatives, plus vancomycin if MRSA is a concern. Clindamycin is also a good option for its bone penetration.
And just to round it out, is there a special form of osteomyelitis we should know about?
Yes, a very important one is Pott's disease, which is tuberculous osteomyelitis of the spine. It presents with back pain, night sweats, and can lead to paraplegia. On pathology, you see caseating granulomas and a cottage cheese appearance from the necrosis.
I see. Thank you for walking us through that, Ghena. So, to lock in osteomyelitis,
Remember the key triad. 1. Bone pain plus systemic signs such as fever. 2. MRI is most specific for imaging. And 3. Bone biopsy is diagnostic. And never forget the treatment combo, debridement plus long-term antibiotics.
okay guys, we're almost there. One final case for today. We have an elderly gentleman who comes in with a strange set of complaints. He says his hats no longer fit him and he's noticed his legs are starting to bow outwards. He also mentions a persistent dull bone pain. We run some routine blood work and one value is through the roof. His alkaline phosphatase is massively elevated. What condition ties all these clues together?
Now that is a fantastic and classic history for Paget's disease of bone, also known as osteitis deformans. The name itself hints at the bone deformation it causes.
Paget's disease. So, what is the fundamental malfunction happening inside the bone?
It's a very chaotic process of disordered bone remodeling. The current understanding of the pathogenesis points towards a genetic predisposition. It's a chaotic process of disordered bone remodeling. The current understanding of the pathogenesis points towards a genetic predisposition, often involving a mutation in the SQS-TM1 gene, which leads to a primary defect in osteoclasts. The disease progresses through 3 distinct phases.
Walk me through those phases, please.
Certainly. Phase 1, starting off with the osteolytic phase. It all starts with hyperactive osteoclasts going into overdrive, causing excessive bone resorption. Then comes the mixed phase, The body tries to compensate by sending in osteoblasts to lay down new bone, but they do it in a rushed, disorganized manner, depositing weak, woven bone that creates the pathognomic mosaic pattern of cement lines under the microscope. And finally, we have the osteosclerotic or burnt out phase, where eventually the overactive osteoclasts seem to exhaust themselves and die off, leaving the osteoblasts to continue depositing bone unchecked, leading to dense but poor quality sclerotic bone.
And this chaotic process explains the clinical picture. The enlarged skull makes hats feel tight, and the weakened leg bones bow under the body's weight.
Yup, while many patients are asymptomatic, common presentations include bone pain, bowing of the legs, and the key biochemical clue, an isolated, very high alkaline phosphatase, which reflects that frantic osteoblast activity in the mixed phase. Patients might literally say, "My hat doesn't fit anymore," or "I feel like my legs can't carry me." The bone overgrowth can also narrow skull foramina, leading to hydrocephalus or hearing loss.
And the bone is hypervascular, right? What effect does that have?
Now, the new bone formed is full of blood vessels, leading to increased warmth of the overlying skin. This hypervascularity can be so significant that it creates atriovenous connections, effectively shunting blood and forcing the heart to work much harder. This can, over time, lead to high output cardiac failure.
And are there other serious complications?
Yes, a particularly worrisome one is the increased risk of bone cancer, specifically osteosarcoma. The disease can be monostotic, affecting just one bone, which is easier to monitor, of course, or polystotic, affecting multiple bones, which makes follow up much more challenging as you have to watch numerous sites for malignant transformation.
So, for treatment, we need to target this out of control turnover.
Precisely. The mainstay of treatment is bisphosphonates, which are powerful inhibitors of osteoclast activity. They help slow down the entire chaotic cycle. Calcitonin can also be used as it also inhibits bone resorption.
That makes sense. Got it now. So, to summarize Paget's disease,
Paget's is all about disordered remodeling in three phases. The hallmark is a massively elevated alkaline phosphatase. Remember the classic patient complaints: "My hat doesn't fit," which hints towards skull enlargement, and bowed legs. Now, the pathognomic histology finding is the mosaic pattern of bone. And don't forget the serious complications: high output cardiac failure from AV shunts and an increased risk of osteosarcoma.
well, everyone, that was a whirlwind tour of the world of bone diseases. From the slow erosion of osteoporosis to the genetic blueprints of osteogenesis imperfecta, to the battlefield of osteomyelitis and Paget's disease. Ghena, thank you so much for breaking this down so clearly.
It was my pleasure, Hala. It's a fascinating and clinically crucial topic.
And thank you for listening to PodBites. We hope this helped make these complex topics a bit more digestible. Until next time, take care of your bones and your mind.
My fat doesn't hit. My fat doesn't hit.
قوي هاي ايش قصدك؟ يا my fat doesn't fit. اوكي حبيت.
Okay.
My fat doesn't fit. غنان.
هذا patient complaint. Okay.
يلا.
Okay, يلا, I'm ready.